Good evening and welcome to another show. Tonight's guest is Dr. Greg Magreni, and we're going to talk about emergency room problems. Stay tuned. Good evening. Tonight's guest, again, Dr. Greg Magreni, works in our emergency room. Greg, welcome to the show.
Thank you, Gene.
Greg's an emergency room physician. Tell us a little bit about how you get to become an emergency room physician, Greg.
Well, it's pretty much the same path that most doctors take. It's the 4 years of college and the 4 years of medical school, and at the end of that, you choose a residency in emergency medicine. There are other docs who have other backgrounds and land in the emergency department because they so choose after completing perhaps a career in another field.
Perfect. Well, tonight we're just going to talk about routine things that bring you to the emergency room. And I guess one of the questions I have and folks out there would be, when do I take myself or my child to the emergency room? What are some of the things that, are disturbing enough to us as we drift in and out this evening to take somebody to the emergency room?
Well, most of the time, if you think that you need to go to the emergency department, you probably do. A lot of people get to the emergency department and are embarrassed to find out that they don't have an emergency diagnosis or don't need emergency treatment, but that's not the parameter that we measure your decision to come to the emergency department by. If you have signs or symptoms that you think are serious, that you think may be life-threatening, or you think are progressing and getting worse, then you probably should be in an emergency department.
Perfect. And my understanding is no matter what, most of the insurers are pretty comfortable with the layman's diagnosis. If they think it's an emergency, then it's covered for the most part.
That's for the most part true,
okay.
Yes.
Because, I mean, a lot of folks out there are like, well, I want to go because I got to do this or I got to do that. And I try to explain to people, especially when they apologize for, whether or not they have abdominal pain, is that we had the benefit of going to medical school.
Exactly.
And you didn't, so I mean that's one of the good reasons to go. Let's talk about the drop-dead diagnoses. We like to educate people out there, and I mean the things that we hate to miss are signs and symptoms. Let's talk about heart disease for one. I mean, I think everybody knows the standard, clenched fist. I'm having some chest pain, but I get to the emergency room. Most people going down your left arm, up your neck. That's pretty. Would you say the average guy out there would know to get running to the ER with that? Well,
yes, heart disease is a little more difficult, as all the visceral diseases are. Then it's pretty easy to know when you break a bone. It's crooked, it hurts. But heart disease is a little more difficult simply because your heart doesn't have a certain place where it's going to tell you it hurts. Okay. Your heart can hurt in your chest, your heart can hurt in your arms, your heart can hurt in your chin, your jaw. So there's a lot of different presentations for heart disease, as well as different symptoms such as shortness of breath, nausea, vomiting. So it's not so easy, and that again is why we don't blame people for coming to the emergency department thinking they have a heart attack, and they don't have a heart attack, because it's very hard to know.
And sometimes we just bring them in because we're not sure. I mean, we have some newfangled tests that we do these days. You want to tell us a little bit about those?
Well, absolutely. They're going to be, depending on your signs and symptoms that you present with, your vital signs, etc., there's going to be times where we don't even know after your emergency department evaluation that you do have heart disease or not, so you would be admitted to the hospital overnight, and you would have enzyme testing, which enzymes would show up in your blood, and you may go on to have a stress test in the morning.
Okay. What are some of the more unusual symptoms that you've seen where somebody comes in you know, they're not sure, and they end up turning out they actually did have a heart attack. What are some of the more unusual symptoms, or do you get to see a lot of very, you know, straightforward, I have chest pain?
No, there are atypical symptoms that people do present with, and it does turn out to be heart attack, and that's kind of a scary thing. You can have pain in your abdomen, you can have pain in your jaw or your neck, or just a dull feeling in your arm, and that could be the only symptom that you have.
Okay. Do you see that more in smokers than non-smokers?
You see it more in diabetics. Diabetics have different symptoms than most other people do.
Right, I agree 100%. You know, when there's a lot of studies out there for gallbladders, and it's somewhat controversial regarding symptomatic or asymptomatic gallstones in diabetics. But I tell them, let's get them out, especially if it's a man, because they'll present in septic shock sometimes. I mean, you know, and they've had absolutely no symptoms, and the families will be like, you know, he wasn't feeling that bad.
Yeah, right.
You know,
exactly.
Didn't want to bring him to the hospital. How about the one I always like is when your child falls, and you know we have plenty of incidents at the Hammell household where kids are falling down steps, either pushed or otherwise, not by the adults, I might add, while playing, sometimes vigorously, and you know, if somebody has something broken, you know, I'll just put some ice on it, it'll be okay. I mean, when should we, after some sort of contusion, bone-shattering injury, when should we come and present ourselves to the emergency department? Again,
it's not real straightforward. There's no hard and fast rule. I can tell you that if you have this, you have a broken bone, and if you have this, you don't. I often hear people say, and it's a common myth, that well, doc, I could break it, or I could move it, so it can't be broken. When, in fact, breaking a bone just gives you another joint a lot of time, another place to bend it.
Yes, we've had some exciting things. Sometimes, I guess, they're pretty straightforward when we attempt to rollerblade down our front lawn. You know, we've sustained some fractures in our crod doing these things. So, I always tell them, if you're going to wear your protective gear and stuff, I guess you should probably also add, don't rollerblade in the front lawn.
Yeah.
Okay.
That's not a very
Tell us a little bit about, you know, since it is the middle of December, how am I doing? The middle of January, I'm still stuck in '07, I don't know why. And what are some of the, do you see any snow accidents, snowboarding, skiing, sled riding?
Oh yeah, we see an awful lot of that. A lot of people coming straight down the mountain to the emergency department. A lot of people just coming straight from their yard or straight from an icy slope to the emergency department. Skiing accidents, snowboard accidents, just people slipping and falling on ice. It's very common in the winter.
Are there any protective things you can advise them other than don't go skiing? I mean, are there any things they should watch out for? Anything that helps them?
I'm not going to be one to tell you not to go skiing, that's for sure.
Obviously, you must be a skier.
But, absolutely.
Okay.
How
about exercise before you go? I mean, is that like important stretching, anything like that, or?
Yes, absolutely.
Just have a beer and get lubricated going down the slope.
Well, alcohol and slopes aren't too good together.
Good. I like to hear that. That's good.
But helmets are a thing that's really catching on. I know it's hard to get my kids, your kids, to wear their helmet when they go to ski, because it's just not cool.
Not cool.
It's not cool. But they're really, you're seeing probably 80% of adults and kids wearing helmets on the slopes these days.
I hate to run into one of those people.
That's why you need your helmet.
I understand. Wow. I try to avoid activities that can injure portions of my body. As I get older and older, I could injure myself stepping out of bed, it seems, these days. Do you see a lot of cold injuries this time of year? We always suggest, you get warm. Do you see any of that?
We do, but most of the time a cold injury is going to be related to another condition. People pretty much don't just go outside and lay in the snow and get cold.
Right.
And don't get trapped outside easily and get cold. But it'll be related to another condition. Perhaps someone will be in a car accident and they'll be incapacitated for that reason. So you have the complicating fact that they've laid outside in the cold for a couple hours. People may become incapacitated for different medical conditions. People may be intoxicated and be outside for a number of hours. And that usually we don't see just hypothermia. It's almost always linked to another condition.
Okay. Again, we have Dr. Greg Magreni tonight. He's our emergency room specialist at Canonsburg Hospital. Greg, let's talk a little bit about you know, this is cold and flu season. When should somebody seek medical attention? You know, they're sick, they're just not getting better.
Again, that's a tough call.
I'm trying to make easy calls tonight. Really.
It's true, and that's what's so hard about making the decision whether to come to the emergency department or not, because it's just, you can have a very high fever with a flu and come to the emergency department and get very little different in advice, except that, you know, keep yourself hydrated and keep yourself nourished. But if you've been sick for a number of days, if you haven't been able to eat, if you think you're becoming dehydrated, if you're getting weaker, if you have a fever that persists, you know, a long period of time, then that's probably a good reason to come and get checked and see if there's any way we can improve on your treatment that you're administering to yourself at home.
Okay. We have a lot of kids that are going to college. You and I will have some next year. Let's say, do you see a lot of, I would assume you don't see a lot of meningitis, but I would assume that that would be a very scary thing that, you know, somebody at college or wherever has meningitis. What are some of the things you should look for, avoid, you know?
Well, meningitis is almost always, there's always a fever involved.
Okay.
You're also probably going to have a pretty bad headache. You're probably going to have a pretty stiff neck, and you're going to be pretty much sicker than you have been probably ever in your life.
Okay.
It's a very serious illness, and it's usually not subtle.
Okay.
When someone comes in with meningitis, we pretty much know as they walk through the door.
Now, who do you, in your practice, who have you seen with meningitis? Is it more the old or more the young?
Both. It would be the
Really?
old and the young. Mostly in the middle, you and I aren't going to get it very much. But yes, very old people and more young people.
Okay.
But the incidence is decreasing now. We have meningitis vaccine and different vaccines against bacteria. So you're not seeing too much, too many people presenting with meningitis.
Okay. Let's talk about kids. Let's talk about two of my favorite topics, which we tend to see this time of year, which is either vomiting and or diarrhea. I would assume in the younger age groups, right after dinner I know, but in the younger age groups, we like to cover these things. I had to bring my daughter and my youngest one time because she was just unbelievably dehydrated. Mm-hmm. I mean, you know, so tell some of the folks out there, when's a time when you're just not cutting it at home and you need to bring somebody to the emergency room?
Well, you can, you know, parents are usually all over their kids, and they pretty much see what's going in and what's coming out, so they're pretty in tune. Most parents are pretty in tune to whether their child is doing poorly. But the best barometer is the kidneys. If you're not making urine, then you're pretty dry. Okay. And you know, there's other things that you can see. You can see that their mouth are dry, their lips are dry. You know, they're not crying tears in the very young children. But the best barometer is going to be whether they're making urine.
So if you're not changing those diapers as frequently as you can, and you know your child's sick, bring them on in, because sometimes a liter or two of saline gets them back on their way to recovery.
Correct.
Okay. Do you see much in the way of another one of my favorite topics, foreign bodies in kids? What's your favorite? What do we normally see? Things in the ears, things in the nose,
exactly,
everywhere?
exactly. Small toys, food, in the nose, in the ears. And sometimes they're pretty tough. Sometimes we can get them out in the emergency department. Sometimes you don't. Sometimes they wind up going to the operating room with the appropriate specialist to put them to sleep and take a foreign body out of the nose or the ears.
Well, we don't like that.
No.
Okay. So keep the young ones away from the small objects.
Exactly. And I think most of the toy industries and most of the people are in tune to that. But somehow still they get their share of foreign bodies.
I gotcha. Do you see much in the way of asthma coming to the emergency room?
Absolutely. Yeah, a lot of asthma. And again, it's worse in the winter. Well, it depends on what sets off your asthma, I guess. In the summer, you see a lot of exercise-induced asthma. In the winter, you're going to see more people with upper respiratory infections, and that's what sets off their asthma. Also, people are inside, a lot of people still smoking, so you're still going to see a lot of that type of like particulate and dust. And Christmas time, the Christmas trees, people get allergies, and there's their asthma.
Perfect. you bring up a subject near and dear. How can somebody out there decide if they've had, or can they? They have to come to see you, whether they have pneumonia or whether they have the flu.
It's, again, a tough call.
I told you I was going to answer all the tough questions today.
Most of the time, I can't tell without a chest X-ray.
Okay.
If they're breathing real fast, if they're tachypnic, that's a sign that they may have pneumonia. If they're short of breath, they may have pneumonia. If they have a persistent fever, if they're coughing up thick green sputum, then that's a sign of pneumonia. But again,
and that's a sign to get to the emergency department.
Absolutely.
Perfect. Can anybody get pneumonia, or is it the different categories where we are?
Actually, anybody can get pneumonia. There's different pathogens that cause different types of pneumonia at different ages, but it doesn't seem, in my experience, pneumonia doesn't seem to target any one age group.
Okay. Do you see a lot, because we read in the newspaper, we're here, especially with all these sporting events going on, do you see a lot of MRSA coming into the emergency room these days?
I do. We do. We probably see a case every other day of someone coming in with MRSA.
Why don't we define MRSA for those that are just tuning in and missed our other discussion?
Well, it's methicillin-resistant Staph aureus, which means it is resistant to a drug that we classically used to treat Staph aureus with.
You ever read for methicillin?
No.
Neither have I.
No.
Seems like an archaic design.
It's a pretty old drug.
Right. Okay. Go ahead. I'm sorry. Didn't mean to interrupt you.
That's okay.
MRSA.
But MRSA, most of the time where we're seeing it is on the skin. You'll see little skin lesions that look like a little spider bite, and you'll culture it, and it's MRSA. And the only difference is, as opposed to any other skin infection, is that you have to treat it with the appropriate antibiotic.
Right. So, because it seems to be, it's certainly something to be very prudent and watch for, but it's not like it's the Ebola virus coming to get you.
Oh, correct. I have not seen, now I don't do in-house medicine, and I don't see inpatients in their course, but I haven't seen anybody have a bad outcome from MRSA. Most of the time I see people who have had a rash that has been pretty stagnant for days, if not weeks, and they come in and say, "What do you think this is, doc?" And we culture it and it's MRSA. But I haven't seen anybody have real bad outcomes with it.
To the average guy out there turning through the channels tonight, describe what would be a typical lesion of MRSA, because you don't want to be dragging. We don't want to see 50 skin rashes and take all the business away from my good friend Dr. Mark Sorelli right down the road tonight, which I'm sure he'd be happy to send all of them to the emergency room. But what should we look for? What are we concerned about?
Well, it's a red lesion usually. The center is usually purulent or pussy. Okay. It's well circumscribed. In other words, it has well-defined borders, so you can see where it starts and you can see where it stops.
Looks like a little volcano.
Yeah, yeah.
I try to make it simple.
About dime-sized a lot of times. One or several little dots.
Yep.
And it usually drains.
Yep. Usually not a lot of systemic or symptoms.
No, usually not. Okay. Usually no fever. Usually don't feel bad or feel sick.
Not itchy.
Nope. Nope. Maybe a little burning or a little pain. Just got this little thing.
It looks like something like Mount Vesuvius, but not that big.
Not that tall.
And it tends not to get better as fast.
It doesn't get worse as fast either.
Correct. So it just kind of hangs
slow.
around.
It just hangs around.
And but we do have plenty of drugs, both orally and intravenously, to take care of these
Absolutely.
issues. Okay. We got to Dr. Greg Magreni again tonight. We're talking about just some ER topics, what would take you to our new emergency room in Canonsburg. Been through there a bunch of times. Got a bunch of really nice rooms and not a lot of waiting these days.
Yep, we have 18 rooms. When you come to our emergency department, most of the time, there'll be an open room and you'll come straight back to a room. And you'll be triaged in the back. Most of our, in fact, all of our record keeping is done by computer now. So the nurses will check you right in, get your vital signs, and get them right up on the computer, and I'll see on a computer screen that you're there and be back as quick as I can.
You have also an x-ray department right in the emergency room, makes things a little more easy.
It is. It does speed things up, the transport to and back from the x-ray suite. It's quick.
Do you see a lot of, I guess this time of year, do you see anything more than anything else, fainting, dizzy spells, any more of that than in the summer, or what other popular things do you see in the winter out here?
Well, winter is mostly, the kids are in school. Everybody's in tight quarters together. Everybody's coughing, and everybody's just exposing each other to bacteria and viruses. And most of the time, winter is upper respiratory illness time, as opposed to summertime being mostly accidents and exposures.
Do you see a lot of, I assume you see a lot of trauma?
A good bit.
Okay. What do you want to tell the folks out there? Because I harp on this every single program, it seems.
About trauma?
Yeah. How to avoid it.
How to avoid it?
Yeah.
I don't know. It's out there. It keeps me in business.
I understand. I tell them not to drink and drive and please wear your seatbelts.
Yeah, all the safety stuff, absolutely.
That helps a lot more. When you have, an acute injury such as an ankle, twisted ankle, you must see dozens of these things.
Absolutely.
How can you tell whether or not, or can you tell whether or not, is it something, if you can walk on it, as you talked about earlier, it's not broken, or is, just like...
You can probably still walk on it, and it probably can be broken. There are rules that we use to gauge how severe an ankle injury might be and whether or not it needs an x-ray. But by and large, if it is swollen, if it's tender right on the bone, of course, if it's crooked, that's pretty obvious. Yep. But most of the time, you come to the ER, you're going to get an x-ray of your ankle if you twist your ankle or if it's more than just a minor injury. And most people are pretty good at knowing.
Okay. We're going to talk some of the topics that I really like to talk about was abdominal pain. Keeps us in business, right?
Absolutely.
How can you decide whether or not, it was kind of funny, I had a guy about a week or two ago, he came in and he's like, well, I have this pain right down here, right down inside. I thought it was my spleen, but I called my wife and she said, no, it's your appendix. I mean, tell us a little bit about how you get appendicitis, or what are some of the signs you see of appendicitis versus just a regular run-of-the-mill cold, cough, flu for abdominal pain.
Well, most of the time when you have what we call viral gastroenteritis or just a stomach flu, you're going to hurt all over. Your belly's probably going to hurt all over, or perhaps up high. And the pain's going to wax and wane. They get better and worse. And a lot of times patients will tell me that they feel better after they vomit, and then the pain goes away, and then the pain gets worse again. And the pain is waxing and waning. Where appendicitis, it's going to be a pretty constant pain. It's going to progressively get worse, and it's probably going to be in the right lower quadrant, of course. And the main way, as you know, that we can tell the difference between an appendix and flu is that it hurts to move.
Okay, good. Thought you were going to say the dreaded CT scan work.
With contrast.
Okay, fine. Appreciate that. Got it. When you have, we talked earlier about abdominal pain and diabetics, and the people that I've seen that have severe problems in diabetics are people that are undiagnosed with gallstones that get gangrenous cholecystitis, almost always in men, elderly men for the most part. Tell us a little bit about the symptoms, the signs of, just say, your run-of-the-mill upper abdominal pain, which you try to differentiate in the ER between gastritis versus an acute abdomen versus ulcer versus gallstone.
Well, upper abdominal pain is it's going to be something that we're probably going to do a little bit of testing to differentiate between those types of diagnoses. We're probably going to need to do an ultrasound to look at the gallbladder. We're probably going to need to do some chemistry tests to see if there's any evidence of gallbladder obstruction, or whether there's any evidence that your liver's sick and you have some sort of liver illness. Probably going to be looking for blood, in vomitus or in stool.
Okay. Tell us a little bit about kidney stones. We got to mention my good friend Dr. Wyrick and Dr. Karamchetti down there. What are the pains you get with kidney stones? Because you guys have to see a bunch of this.
We see a lot of kidney stones.
Okay.
And kidney stone pain is going to be a pain of pretty sudden onset. The higher the stone is, the higher it hurts. Typically, when at onset of a stone that's starting up in your kidney, it's going to hurt up in your high back. And as it progresses down your ureter, which is your tube between your kidney and your bladder, it is going to hurt lower till it comes around the front and hurts down into your groin. It's a colicky pain. Again, it's a pain that gets better and worse, and it doesn't matter. People are miserable.
Right.
It's a real bad pain, one of the worst pains you can have, and it's a pain that you just can't find a comfortable position. And again, that's the way we're going to try to differentiate between a kidney stone and appendicitis.
Right, absolutely.
Because the kidney stone person's going to come in squirming, and the appendicitis person's going to come in staying very still.
They don't want to move.
They don't want to move.
I'm with you 100%. We've covered a lot of ground tonight regarding common medical emergencies. When do you dial 911?
You dial 911 if you think you need to get to the hospital quickly. You dial 911 if you think your condition may deteriorate on the way to the hospital. You would dial 911 if you don't have anybody to take you to the hospital and you don't feel like you can drive yourself to the hospital, or if you feel that there's no other way for you to get to the hospital. A lot of people out there are alone at home and don't drive, and that's their only way to get there.
Right. So nobody will give you too much of a hard time as long as you're, again, feel that there's some medical emergency.
Actually, you don't get too much of a hard time.
That's good.
We're on our own to tell whether we have an emergency or not, and people by and large believe that you were genuine in your thought that you did have an emergency.
I see you now have a helicopter parked outside of your emergency department.
We do. We do.
Is that only when you're on there, or me?
No.
Okay.
It's there 24 hours. It flies 16 hours. Ours does. The ones downtown fly around the clock. And it's been pretty busy. It's been there for about a couple of months now, and it's been pretty busy. It's a nice asset to have in our county.
Perfect. And that's, you say it flies 16 hours. They don't fly at night?
That one's not flying at night. That one's not covered at night. But again, we have access to helicopters around the clock.
Right, I figured as much. So, it's really kind of neat that you can, you can handle virtually every emergency at the hospital.
Absolutely.
And,
Absolutely.
the traumas, the big stuff's going to go downtown regardless, but we have a helicopter. We can.
Yes, trauma these days almost exclusively goes downtown. The experience in medicine has evolved over the last 20 years, and it's to the point where trauma is really not serious trauma that needs to be hospitalized. It's not taken care of in the community anymore.
It's got to go to a level 1 trauma center.
Absolutely.
Okay, we've had Dr. Greg Magreni. We've had an excellent mishmash of, I think, virtually every topic that could possibly bring you to an emergency department.
We hit a lot of them.
I think we hit most of them. We didn't talk about eye injuries, but we're going to have an ophthalmologist on later this year so we can talk about that. If your eye hurts, go to the emergency room. How about that?
That's fine.
That pretty much covers it. Greg, thanks for coming tonight. I'd like to thank the high school students who are diligently here rather than doing their studies or going down some ski slope this evening.
Without their helmet.
Without their helmets. We'll see you in a couple of weeks with Dr. Dave Berkey. Stay tuned. Be safe. Don't drink, don't drive, and please stop smoking.